much for the organizer for giving me the opportunity to talk today. And I will begin with two cases which nephrologists could encounter one day or another. The first one is a 36-year-old prima gravida with no medical antecedent, and we know from the prenatal checkup that somehow she had mild anemia and thrombocytopenia. In the 30th week of gestation, she developed hypertension, leg edema, and there was also fetal growth restriction, and this was the reason she was transferred to us. The same evening, she developed severe preeclampsia with AKI, a severe thrombocytopenia, a proteinuria 3+, and also a loss of variability on CTG, and this was the reason why cesarean section was performed. Hypertension and creatinine improves, but the following day she still had proteinuria, anemia, and quite a high grade of thrombocytopenia. And this was the reason we thought there could be something else behind. And then we did those antibodies screening. We found high positive antibodies against DNS, low complements, and so we made a diagnosis of systemic lupus erythematosus. After the patient got IV steroids, the proteinuria decreased from 3 to 1 gram, and the hematology normalized. So far for the first case. The second case is not that dramatic. 30-year-old female patient, lupus diagnosed 5 years ago with renal phenomenon, polysynovitis, and proteinuria, but for the moment on the prednisone, MMF, and hydroxychloroquine, she was quite stable, just a slight photosensitivity in renal. And of course, the patient who just got married is coming for counseling because she'd like to become pregnant. And so based on those two cases, I would like to discuss those two topics. First, shortly, when is preeclampsia not just preeclampsia, but a first manifestation of lupus? But then afterwards, the bulk of my time, I'll talk about the management of pregnancy in patients with lupus. Now, if you come to the first topics, I must say that until 1 year ago, there have not been so many literature on that, only case reports and retrospective studies. Until last year, there was this very interesting study from Pavia, where the people prospectively enrolled all women in the first trimester of pregnancy attending the clinic. They had a 10-item questionnaire with symptoms of connective tissue disease, arthralgia, rashes, syndrome, and then autoantibodies were done. And so of the 5,000 or so women who complete the questionnaire, you can see that 511, so roughly 10% has really definitely a positive questionnaire. In those patients, 68% has positive autoantibodies. So to make a long story short, major connective tissue disease was diagnosed in 1.3% of those patients. Lupus is in 0.25%. But this has far-reaching consequences on the pregnancy because the odds ratio for preeclampsia was 9.2 and for intrauterine growth restriction was 8.8. Besides, there were so-called undetermined connective disease in another 2.5%. So what about now pregnancy in patients with lupus? So what do you have to do when such a woman comes to you and you want to counsel her? So first you have to warn her about the maternal and fetal outcomes in lupus. So we know that definitely one of the biggest problems are flares. You find them in about 30%, and interestingly, hematological and renal flares are more often than musculoskeletal. Preeclampsia in up to 30%. So 3 to 5 times higher. And besides the risk factors which I've already mentioned by the previous speaker, you have specific risk factors, which is active or history of lupus nephritis, antiphospholipid antibodies, declining C3, and thrombopenia. And of course, you have higher mortality. What about the fetal outcomes? You have abortion in about 15% of the case, premature birth up to 50%, and fetal growth restriction in up to 1/3 of the cases. A special case is a neonatal lupus, which is acquired anti-Ro antibody from the mother with rash, anemia, elevated liver enzymes. Those are reversible, but the most serious complications are the cardiac complication, including congenital heart block with a high mortality. So how should we advise those patients? There are situations where you have really an absolute contraindication to pregnancy, severe pulmonary hypertension or restrictive lung disease, advanced renal insufficiency or heart failure, and of course, previous severe preeclampsia or HELP despite therapy. And in some cases, pregnancy should be deferred. For example, when the patient has had a disease flare within the last 6 months, or a stroke, or an active lupus nephritis. Now, once you go through that, you still want to plan the pregnancy with the patients, and then you have to know about antenatal management. So in the evaluation, you have first to assess the major organ function according to what I've told before about risk factors, and assess disease activity, cardiopulmonary function, so don't forget the lung as well, the kidney function, liver parameter, thyroid function as well, because we know that hypoparathyroidism can be a risk factor for preeclampsia, whole hematology, and complement system. Now, especially the autoantibodies should be tailored to this case, so you have to do also the antiphospholipid antibodies and also the anti-SSA and Rho antibodies. I won't talk too much about pharmacotherapy because we have already seen that in the previous session. Just want to mention that in the special case of lupus, you should continue antimalarials because they have been shown to reduce the risk of flares during pregnancy. We also give them low-dose aspirin after the 12th week, and some Cochrane review have shown that calcium also can reduce the risk for preeclampsia. Stop ACE inhibitor, avoid diuretics, because in the case of pregnancy, if you give too much diuretics, the patient are going to be hemoconcentrated, and this will worsen the hypertension. And then we give those classical hypertensive drugs in pregnancy. Folic acid, of course, vitamin D, and magnesium if they have seizures. Now, the antenatal management, I think the most important point is it has to be multidisciplinary. And we have indeed at the University Hospital a whole team consisting of rheumatologists, nephrologists, obstetrician, and then we talk together and we see the patient 4 to 6 weekly, more frequent if there's active disease or flare. I have to mention the specific monitoring if the patient has anti-Rho antibodies, and so you need their fetal echocardiography weekly until week 10 and 6, and then biweekly thereafter because of the heart block. Now, one of the things is, this is not that trivial. How could you recognize lupus flares? Because as you can see, in pregnancy, you can have all the changes which could also point out for lupus flare. For example, anemia. You can have mild anemia and thrombocytopenia in normal pregnancy, but you have to look for immune hemolytic anemia or severe thrombocytopenia for lupus. Likewise, you can have a physiologic proteinuria, which is much worse. You can have, and then you can also have the complement levels. This is quite a difference because they are high in pregnancy and they are falling in the flare. Those are the recommendations of the EULAR from the year of 2012. So basically, pregnancy can be planned in stable patient with active lupus for the preceding 6 months and with GFR above 5 ml per minute. The medication are the one I've already mentioned, and flare during pregnancy can be treated with the same medications as stated above. Now, I want to say some more thing about this, why we should be so careful about this, because you have heard that preeclampsia is a systemic disease with cardiovascular problem. So you have an accelerated atherosclerosis, as it has been shown this in this paper, that you have in these young patients much more atherosclerotic plaque when you compare them with control. So this was one of the papers in 2003. This is also our experience in the Swiss lupus cohort study. As you can see here, 85% of the females had an age of about 35 as we diagnosed them. Nota bene, we had 4% pregnancies during follow-up. But if you look at those hard endpoints, then you have in those very young patients, coronopathy in 6.5%, myocardial infection in 3%, peripheral vascular disease in 1%, and the whole will amount of 16.3% of heart atherosclerosis endpoint in those patients. The problem is quite complex, and so it goes from immune dysregulation to complex deposition, tissue inflammation, at the end fibrosis and damages. So the same pathway bringing end-stage renal disease will also bring myocardial infarction and thrombosis. So my take-home message, preeclampsia could be the first manifestation of systemic rheumatic disease, and in the era of cardiac MRI and a sophisticated lab, you have first to talk with the patient. Pregnancy can be planned in stable patient in the first 6 months. You have to be careful about those special antibodies, the phospholipids, anti-SSA. As medication, hydrochloroquine should be given, and also low-dose aspirin. Very important is the multidisciplinary team, And of course, the whole story is important not only for the short, but also for the long-term prognosis. I'd like to acknowledge the multidisciplinary team for the US Hospital, nephrology, rheumatology, gynecology, the people contributing to the Swiss lupus cohort study and the foundation. And I would also like to acknowledge the wonderful view which helped us treating those patients. And I'm ready for questions. Thank you.
So we've got plenty of time for questions from the audience. Let me just start off with a question. In terms of the lupus flare, the first case you presented, so a patient presenting with acute flare during pregnancy, yes, you're going to pulse with steroids. What else can you do to, protect kidney function and ensure optimal maternal and fetal outcomes apart from your pulse steroids?
You mean in the first case as the first presentation? Yes. So basically, it's the same thing that you really have to have an ideal blood pressure control. And then, of course, you can give aspirin, give also calcium, and we give magnesium. So this is the basic. And in this case, the patient responded quite well to the pulse steroids.
But nothing else in terms of immunosuppression modulation?
Yes, hydroxychloroquine, you can give it even in breastfeeding women afterwards, so you can give it during pregnancy. Thank
you. Question from the floor?
I was just wondering, when you've had to use rituximab to induce effective remission in the build-up to pregnancy, how long would you wait after rituximab before allowing them to fall pregnant?
Yes, so we know that belimumab and rituximab should be stopped for pregnancy, so usually we wait at least, there are no studies actually, but I prefer to wait at least 6 months. So they have to be stable, so this is not only the question of the medication, but also stability.
I might just make a point or two actually. I think one important point is that lupus nephritis is quite different, or any visceral lupus, quite different from the much more common cutaneous and joint lupus, which actually has no negative impact on pregnancy outcome. So the renal lupus is what you were talking about, and is associated with all those poor pregnancy outcomes, in particular fetal growth restriction and preterm birth and stillbirth to some extent. I think that's an important thing, because most women have lupus that is contained to the skin and joints, certainly in a rheumatological setting. The other thing about congenital lupus, it's confined to those who carry the Rho and LAR antibodies, as you said, but only 1 in 50 of them will actually have alloimmune. All the antibodies will cross to the fetus, actually. So all those women who carry those antibodies, they do cross easily to the fetus, but only 1 in 50 will cause congenital heart block. And picking that up is something that takes a bit of time with our fetal medicine service, but generally at the very earliest it'll come on at 18 weeks gestation, and at the very latest 30 weeks. So there's your window to study. If it hasn't come on by 30 weeks, it's not going to come on. Yeah, sure. But the fetal medicine guys are very clever at picking up first degree heart block, second degree heart block before complete heart block these days. The question is, when you find it, what the heck do you do about it? And how can you, and you can't really reverse it, is what you were alluding to. So there are studies looking at whether steroids, dexamethasone, which crosses over to the fetus, might have a role to maybe protect the myocardium from the heart block, rather than change the heart block itself.
Yes. So for the first thing, lupus nephritis, yes, there have been recent studies, cross-sectional studies, looking at which factor from, for example, lupus nephritis or antiphospholipid antibody would be more predictive for development of arteriosclerosis, and then obviously lupus nephritis seems to play a role. And I think this has to be with the general inflammation that you have there. And for the second thing, I think, yes, with this heart block, this is because our obstetricians are very keen at looking for that, and this is why they do it quite early. But and sometimes they give steroids as well.
Another question from the floor.
Excuse me, Dr. Tari from Iran. What is your program for decreasing proteinuria during pregnancy? Which drug you are allowed to use, and because you don't use ACE or ARB, or spironolactone, what drugs you suggested? Because none of the drugs you suggested not good for decreasing proteinuria. And the second question, if you need anticoagulation, because lupus nephritis actively or phospholipid syndrome, what anticoagulant therapy you suggest during pregnancy?
Yeah, so I begin with the second because it's easier. So you can't give coumarin, but there's no problem giving heparin. So this is no problem. So you can, pardon me?
Unfractionated.
Unfractionated, but you can also give fractionated. So both IV. Unfractionated is no problem.
Well,
you have depending on the kidney function, but we can give that. And then with aspirin, so this is no problem. Now the main question is, how if you have severe proteinuria, what should you do? Now the point is, you can't give the S and ARB, and so what you can do is, of course, to try, because one of the reason is of course when the blood pressure, it has been mentioned before, is not well controlled. So you try to get the blood pressure as well controlled as possible, and then with this you can have one part of the proteinuria away. The second, if proteinuria is still, you can still ask yourself whether this is still a manifestation of lupus. So in this case, you have to try to treat. For example, you can try steroids to see whether it responds to steroids, but this is still a big problem.
What is your? I suggest, for example, non-dehydropyridine calcium channel blockers, but which was not suggested as your drug therapy, and they are very good for control of proteinuria in the patient who not tolerated ACE or ARB. I suppose that non-dehydropyridine calcium channel blockers is missed here as a component of armamenturum for control of proteinuria of lupus nephritis and blood pressure control as a whole. I suggest that it should be suggested here also.
Sure.
Thank you.
I mean, if I may comment on that issue, you've got to stop the ACEs and the ARBs. They are teratogenic, especially in the second and third trimester. But and so you've got to let the mother run with heavier proteinuria during pregnancy, and usually that's not a problem. But when they get over, in an obese mother, 1 gram per 24 hours or 100 milligrams per millimole on a PCR, or 3 grams, 300 milligrams per millimole in a slim woman, we would start low molecular weight heparin by way of thromboprophylaxis. Pregnancy is a thrombogenic state. Add in nephrotic syndrome on top of that. They're high risk of thrombosis. So you let the proteinuria go up, because you just can't use those ACEs and ARBs, but give them thromboprophylaxis, protect them from what you can do.
Yeah, we give them quite early as well, this low molecular weight protein.
Low molecular weight heparin is the thing. It doesn't cross the placenta. It's safe. Yeah.
Okay.
If I may, thank you for a very nice review. I still have a question. Oh, sorry. Yes.
Okay,
thank you.
sorry.
What is the value of assessing soluble FLT1 to PLGF ratios, or assessing other oncogenic factors in this setting?
Well, we are in the setting of preeclampsia that we know if this ratio is above 95% of percentage for most of the people, then it would mean this is highly pathologic, and in some case there are some interventions which have not been really proven in a randomized study to bring something, which is plasmapheresis. And I think there's, for the moment, this is still open. We have done this in case we were desperate. In other cases, if you don't want to do something, I think combined with a very severe hypertension, etc., is one of the reasons when you have to and if the patient has severe preeclampsia, so one reason you have to, depending where you are, to seize the pregnancy. Yes. But maybe you are the best person to talk about that.
I will talk about that in my talk, actually, a little bit. It's in fact, they're not clinically really used at the moment, still being tested for their clinical utility and for fear of doing harm, but I'll talk about that in a moment.
Okay, thank you.
Thank you very much indeed, Dr. Wynne. So let me introduce our next speaker, my co-chair, Dr. David Williams from London in the UK, and David will speak on immune regulatory and vascular changes prior to the onset of preeclampsia.
Thank you.